with us Dr. Dr. Divyesh Desai, who has agreed to join us for today's tea time session. So Dr. Divyesh Desai is actually not a, is we are all very familiar with him, and he is a pediatric urologist and director of the Urodynamics unit at Great Ormond Street Hospital for Children, the NHS Foundation Trust at London. As his subspecialty interests are bladder dysfunction and urinary incontinence, posterior transplantation, and neurodegenerative anomalies. He has many publications and textbook chapters to his credit. And for today's session, we will go through some case presentations, and Dr. Divyesh Desai will help us.
Short summary of the case. So I had remembered from my memory, sorry, I don't really have the case in front of me, not records, but through memory, let's see. And I had a few questions for Dr. Desai as well as we go further in the clinical history, very routine questions. So this is a 2-month-old boy with PU valves. There was no VUR on the MCU and he was fulgurated there and then itself. The typical, we call it either ablation or fulguration. Put on routine antibiotic prophylaxis and also anticholinergics, which are usually given by our pediatric surgeons till 5 years of age. That was the first question which I wanted you to address later, that should every child be on anticholinergics, that is oxybutynin, till 5 years of age? This child had a few breakthrough UTIs despite the first fulguration in the interim while he was on Septran, and he was treated with augmentin for the same. And since it was happening not more than, it was more than once, not once, so therefore the prophylaxis was changed to nitrofurantoin, and surprisingly he was fine after that. NFT worked very well. A check cystoscopy usually is our protocol after 6 months, and the residual valves which were seen again were ablated. The DMSA scan was quite fine, no scars at all. The nitrofurantoin prophylaxis I had continued for around 1 year, I remember distinctly, post the last infection, and I had stopped. Then there were no UTIs after that. Thriving well on bicarb supplements with a normal EGFR. So like a very normal hunky-dory story of PU valves in the first few years with a creatinine, the best was 0.45. I also managed to stop the bicarb supplements by 4 years of age, and oxybutynin was stopped, as I told you, only at 5 years. It was continued. Though the child developed continence at around 3 years of age, the parents said that, but this was going on as per the surgical protocol. And here the mother said there was occasional nighttime bedwetting. So some preventive measures, which we usually do for nocturnal enuresis in other patients, was also told. And things were settled. There were no such problems that time. And also, yeah, just to add to the list, the ultrasound scan was normal with normal kidney sizes on the centiles around 50th, and bowel wall, sorry, bladder wall thickness was around 2 millimeter. And the post-void residues were slightly high, 20 to 25%. I don't know whether we could attribute that to the oxybutynin, which was going on for a while. And then because of this raised PVR, which was constantly seen around 20 to 25%, not so bad, but on the borderline. So he was encouraged. The parents were told to ask the child to empty the bladder fully. And then there was a little bit of urgency, the mother said, in the daytime. So considering detrusor hyperactivity just on the history, maybe we were wrong or what, he was given a trial of tolterodine after oxybutynin was stopped. This was after the age of 5 years. I distinctly remember that. So that was given for 1 month, since it's an OD dosage. So children really are happy to take that. And there was some relief in these symptoms. But again, the post-void residues were increasing. I think they went up to more than 25-30%. So we stopped that as well. And then now at around a few, I think around 6 months ago, when he was around 6 years of age, now he's 6.5. This was the typical complaint which started, that the child developed secondary daytime incontinence, and he used to wet the underpants. The mother gave this history, particularly when he was arriving from school in the late afternoons while he was in the school bus, and he would have to rush to the toilet on reaching home, but he was again wet by the time he voids. So the mother had this typical complaint of bedwetting and rushing to the toilet coming from school in the late afternoons. And after that, he said in the evening times and in the morning, even at school, there was no such complaint from the teachers, and at home also. So this was the typical only once uh, during the school bus time. There were no nocturnal symptoms of incontinence. The stream, according to the parents, was still good. Then, as always, we do a voiding diary. So his voiding diary showed a very good bladder capacity. For his age, it was around 180. So his was 150 to 170 ml. And his frequency was not more than 7 to 8 times per day. And he had a good water intake. And our typical bowel bladder dysfunction, we made sure that there was no constipation. He was having a good water and fiber intake. No evidence of hypercalciuria. And then he underwent the uroflowmetry and the urodynamics to assess what's happening with the bladder. So this is the history. Anything else, Dr. Divyesh Desai, you want to ask in the history, or should I just show you the Euroflows and UDS?
No, that's fine. Show me.
That's
Let's
fine.
have
Okay, thanks. Yeah, so I'll just show you that. Yeah. So you can see, sorry, we can't zoom in on the PowerPoints, but hope you're okay with the Euroflow, and this is the Euroflow, and the next will be Urodynamics after that.
Okay, just give me a second. So is the voided volume 180? What does it say?
Yes, it says 180. We void 180. Yes, correct. You're right.
Okay. Yep. Okay.
Okay, I'll move on to the next.
Yep.
Right. And that's the UDS.
Is this the entire? Okay.
Yeah. The voiding phase on the next, yeah.
Sorry, the scale on the left is not very clear. Is it up to 100? 200?
Yes, 200, yeah.
200 or 100?
Sorry, where are you asking me? In the filling phase, right?
No. In the voiding phase, you know, the scale on the left.
Okay.
0 to.
Yeah, 0 to 100, 100, 0 to 100.
100.
100,
Okay.
yeah.
Okay. Okay, and this is done via urethral catheter?
Yes, absolutely.
Okay.
Yeah.
Okay. Okay.
Fine. So I think that's the last, yeah. So you wanted to know what's happening and what should we go ahead with this child then now for these daytime, particularly the late afternoon dribbles which he has. Yeah.
So very simple bit of further probing with the child as to whether the child uses the toilet at all whilst at school. So what is very typical, at least what we see at this age group, is that etc. And the fact that he's getting these symptoms only once, which is on his way home from school,
Yeah.
I would first question how regular is his bladder emptying when he's at school. Because if you have ongoing bladder dysfunction, it would not only present itself once a day. And it's happening typically at the same time. Typically, you know, it would be worth checking with mom what happens when he's at home on weekends. Does he still get that? Or at home when he's at home on Sunday, school holidays, there's no problem.
Yeah. So to answer that question, I also asked her the same question. So she said at school, I mean, when he comes back from school, when he's there in the late evenings at home as well, he just goes and voids. But
Correct.
the void is like sort of, it's not, I mean, they were not accepting that the flow is poor, but according to them, they were just fussed about this late afternoon thing. Otherwise, they were fine with other parts of the day.
Yeah.
That's what, yeah.
But that's the bit that nobody knows except the child.
Exactly.
So you can only make assumptions that yes, he's using it. But if I go back to my school days, I can think of many occasions where I will not have. And it will depend on the weather and depend on so many factors. So the more important question is not focusing on the school day. What is happening when he's not at school? Is he still having the same symptoms? And I suspect the answer is going to be no.
No, yeah, right. It's no, correct.
So, in terms of the Euroflow, yes, on the Euroflow, there does appear to be a reduced both maximum and average flow rate.
Yeah.
But in the voided volume, again, what you don't know and what is really important to try and replicate is what is the normal behavior for this child. So when they come for in a test environment, they tend to do things that are not necessarily always normal for them. So if they're told they have to do this flow before they can go, at some point where they feel that they are going to be able to produce a flow, they will go and do it. Because if you look at his bladder capacity on the invasive urodynamics, it is actually more normal. So it is about 240.
Correct.
And if anything, the voiding pressure is a little above the normal, but it is not unexpected because he is voiding around the urethral catheter. Even if you have used a 6 French double lumen, for that age, the boy's urethra, this will be occupying at least a third, if not half of the lumen. So getting him to void around the urethral catheter is bound to produce some additional detrusor contraction in order to overcome that additional resistance. The pattern of the flow actually looks fairly bell-shaped overall in terms of the detrusor profile during voiding. There is a little bit of overactivity at end fill, which is not surprising because he's probably got to capacity. But in the filling phase, things are pretty much quiet, very stable bladder, compliant bladder, and with a little overactivity just prior to voiding. So overall, I would say that this is pretty much a normal situation, and they just need to try and ensure that he uses the toilet at least once at lunchtime, probably. And the main symptoms the parents are concerned about should sort itself out.
Right. So, sorry, what was the last bit you said, the last sentence? The main thing, what?
The main thing is to try and get him into a routine where he empties his bladder at lunchtime.
Yeah,
and
after that, yeah.
Yeah, and then that, which is the main concern of the parents. They are otherwise, very
Right.
happy. So, and that I think is more likely than not to do with the fact that he probably does not regularly use the toilet when he's at school.
Right. So maybe that's the only. So do you feel that are these? Are these patterns on the voiding phase suggestive of a bladder outlet obstruction?
No,
not really.
No, not really, because I would say two things. The first is with the urethral catheter. So, assuming that check cystoscopy has confirmed that there is no residual leaflets, which it appears to be on the check cystoscopy, the possibility of the bladder outlet being obstructed significantly is not in keeping with either of his symptoms or of any other urodynamic parameter. So you've got slightly elevated. They're just so normally in a boy, you would say 40 to 60 is a very normal voiding detrusor pressure. His is a little bit higher, but then he's trying to void around the urethral catheter. So, that is going to have a contribution to those pressures. And I would be glad to try and ensure that first you get the pattern or the frequency of voiding right. And if he becomes asymptomatic, actually, as he gets older, repeat a flow at a point where he would normally take himself to the toilet to void, rather than, okay, this is a test, you have to do it. And, children can be quite compliant, and beyond the age of 5, they are able to void on demand, even when the is not very full. But that represent what is normal. So according to parents, the stream normally at home is very good, which fit with what you're seeing in the test environment.
Correct.
So when you have that mismatch, you have to repeat in the first instance, just repeat and do it in a way in which you can try to replicate what is normal for that.
Fine. And if you look at the Euroflow also, like we are not very satisfied with the bell-shaped curve. So would you want to comment on that?
No, as I said,
It's a urethral catheter, yeah.
yeah. No, but Euroflow, no catheter.
Euroflow doesn't have, yeah, sorry,
Yeah,
Euroflow doesn't
Euroflow,
have. Yeah.
but what this is that the voided volume may not be at a point where he is actually thinking that he really needs to go. And he has attempted to void, maybe, tried to squeeze whatever he can out. It's, on a one-off, I would not make any uh, uh, significant management changes. So I would, in the first instance, repeat it and encourage him to wait until he really feels that he needs fast urine.
Okay.
And if that continues to show a pattern which is not in keeping with what one would expect from his symptoms, that is, it's not a bell-shaped normal flow curve, then you can start to consider what may be the underlying cause. Now, it is not a decompensated bladder. In terms of obstruction, the possibility of a stricture, I would think, is low. If you were able to pass a catheter quite easily for the urodynamics, then it would be unlikely that there is a significant urethral narrowing.
Yeah,
and
exactly.
Moving into the territory of something that is quite uncommon, although not known, which is a secondary bladder neck problem. But those are very, very infrequent, and you need to very carefully monitor over a period of time to confirm that that is the case. Now, going to the early management again, obviously, firstly starting anticholinergics before even a check cystoscopy, I don't see the benefit or the logic of that. The second is, if you look at the natural history of what happens to these or how these bladders behave after the obstruction has been satisfactorily treated, is that for a period of time, usually about 2 years or so, up to 3 years, they continue to have some detrusor overactivity. And that is a reaction to the fact that this bladder has been obstructed from in utero.
Correct.
For a long period of time. And the natural history, when you don't do anything else, is that over time, the detrusor overactivity spontaneously begins to settle down. Bladder capacity begins to increase. And so giving anticholinergics up to the age of 5 could possibly be one of the reasons why he was having significant post-void residuals. Because initially, certainly prior to toilet training, bladder emptying is usually incomplete. And you can potentially worsen that by giving anticholinergics.
Yes. So, just a few, last question would be till after the child is toilet trained, usually by around 3 years. So up to 3 years, we should continue anticholinergics and then stop it after the child is toilet trained.
No. What I'm saying is that the overactivity will spontaneously resolve without anything anyway. That's what the natural history shows. So if you look into what is the pathophysiology as to why are you getting detrusor overactivity? Detrusor overactivity is occurring because this bladder has been working against a resistance.
Right.
So if you take it to the other end of the age spectrum, which is in older males who start to develop prostatic hyperplasia, this is the classic symptoms. They start with getting increased urinary frequency, they begin to get urgency, then they begin to wake up a couple of times at night. And this is because the bladder is working against an increased resistance because of the prostate.
Right.
And if it is managed and treated relatively early, whether that is with alpha blockers, whether that is with finasteride or whatever else, these symptoms generally tend to improve because the bladder is now no longer. And certainly after a TURP, if it is done early, before there have been irreversible changes in the bladder, most of these symptoms will resolve. So therefore, it is a question of which is first and what is happening as a result of that. So first is the obstruction. The overactivity is a response of the bladder to the obstruction. Once you treat the obstruction, you have to wait for the bladder to then recognize that I no longer need to work that hard because there is no longer that resistance. And it will settle down. That's the natural history.
Right. So, I mean, coming down to this, so should we really not routinely give anticholinergics post fulguration?
So we certainly don't.
Okay.
There are there are there are people who believe that it is of benefit, and from a purely scientific point of view, my question would be, unless you do a randomized control trial where you give half the group anticholinergics and half the group are given nothing, and then compare at 5 years, for example, my gut instinct, based on what we know over a number of years about the natural history, is that you're not going to be able to show any additional benefit of giving anticholinergics.
Right. Fine.
So there has to be a benefit.
Hmm.
I'm not saying it's a good thing or a bad thing. My question is, I'm not convinced of what is the benefit. So if something is going to improve anyway, why give medication
For that, yeah.
for something that you just need to be patient? And for the first 2 years, 3 years of their life, at least, okay, here maybe they attempt to toilet train earlier than it is in the West. But in the West, up to 3 years, child remaining in nappies and pampers is very normal. So even if they have overactivity and they are leaking, it doesn't matter.
Right. Okay. Great. And I mean, sorry, I'm just saying last and last again and again.
No, that's okay.
No,
So
we
if
have more cases.
yeah, I think we'll just stop here. Thank you. Thank you so much. Yeah.
No
I
problem.
have just one question regarding this, Dr. Desai. Can we just go to the picture of the urodynamics? Okay. So anyway, we pulled it off the screen. That's fine. I have a question. How do we make out that the prolonged voiding is due to the catheter, which is always going to be there in our case? We don't put a catheter suprapubically. So is there any way of judging that this prolonged voiding is due to the catheter in the urethra and not
No, I
because
don't
it's
think so.
pathological?
Yeah, okay. I don't think so. There are many challenges, I would say, with trying to do these studies per urethra. So the first is that in some of these children, even at age 4 or 5, if they have a high bladder neck, I don't know if you all routinely catheterize children with valves, but it can be very, very difficult, because you can negotiate the urethra, you can get into the posterior urethra, but because the bladder neck is very high, sometimes it's difficult to maneuver it into the bladder. The second is that during voiding, particularly if they're generating high pressures, it's not unusual sometimes for this catheter to get displaced. So when you do it as a video, you may sometimes see that the catheter has now dropped, okay, or it has moved out. But if you just think of it from a very practical point of view, attempting to pass urine around the urethral catheter, even in an adult, is not the easiest thing to do. In a child, 100% it is more difficult. So you have to accept that, yes, you are avoiding anesthetic and all the rest of it, but then you interpret the results with a pinch of salt. And therefore, on a one-off, is what I said, on a one-off, I would not make any overall. If I look at the clinical story, if I look at the renal function, which seems normal, he appears to be pretty much continent, other than this afternoon coming back from school scenario. The voiding pressures, if anything, are, there is good detrusor contractile function, and the bladder is of good capacity and normal compliance. So what am I going to improve here?
Okay, thank you very much. So are there any more questions? Does anybody else want to ask anything regarding this case or this urodynamic pictures or the uroflow? Okay, so then I will request Dr. Madhura Fadnis to go ahead and project her slides, to share her screen. Meanwhile, I will introduce her. Dr. Madhura Fadnis Karadkar is a consultant pediatric nephrologist in Pune. She is attached to the Bharati Vidyapeeth Medical College as a primary pediatric nephrologist there, and is also attached to various hospitals like Global Hospital. Over to you, Madhura. Madhura, we can't hear you.
Hello, ma'am. Am I audible now?
Yes, you are.
Yeah.
Go ahead.
Sorry, ma'am. That was. So good afternoon, sir. There's this 9-year-old girl who presented with increased daytime frequency with urinary incontinence. And also, the mother gives history that the daytime incontinence, that she has never attained daytime dryness. And the daytime incontinence is usually 2 to 3 times a day. She also has primary enuresis with daily wetting of the bed. Then there was also fecal incontinence noticed, and on detailed history taking, it was realized that she was constipated with Bristol score of 2. So initially, her ultrasound done showed all other things parameters normal with a pre-void of 90 ml, bladder wall thickness normal, and post-void of 3 cc. So this was the voiding diary, which showed the volume, the total number, duration, frequency of 11 to 12 times with small voided volumes. So, considering urinary incontinence associated with this, initially Euroflow was attempted. So, 2 times when it was done, the voided volumes were quite less. She wasn't able to hold urine more than 90 ml, and the Qmax achieved was also low. So then she underwent urodynamics. So this is her graph of the filling phase. And this is the voiding phase of the urodynamics. So her parameters looked like there was some overactivity during the filling, and in the voiding also there was EMG activity during voiding. Sir, I had a couple of questions. That during the filling phase, like how can we measure the compliance uh, in this patient? So as we can see, the bladder pressures are quite increasing in like towards the end mostly. But can we say that the bladder is poorly compliant?
No. So the voiding diary, the one thing that is out of sync with everything else that has been presented, including the history, is the voided volume at 8:30 in the morning, which is 300 ml. If you look at all the other voided volumes, they are less than 100 ml, which is in keeping with most of the other times you have attempted to assess and do Euroflows, etc. According to me, assuming that her spine on examination appears to be grossly and broadly normal, the first thing that would come to mind to me is that she has an idiopathic overactive bladder. And the symptoms as well as the frequency volume chart would be in keeping with that as the primary diagnosis. When you talk about compliance, so there's a couple of things to remember, that the point at which you are seeing the bladder pressures sort of go up is the point at which she's probably getting to the point of marked urgency and needing to void. And therefore, that is not your, in the true sense, end point of bladder filling. Okay, because it has merged into what potentially would end up being a precipitous void. So she's hanging on, which you can see with the increased EMG activity. So she's desperate to empty the bladder, but she's holding on, and that's why you've got increased EMG activity. And whilst the urethral catheter is still in situ, so you have to take that into consideration. And you've got a small voided volume with a max flow, which is 21, which to me, in a more normal scenario without urethral catheters, etc., if you are seeing a tower-shaped flow curve, doesn't matter what the volume is, then that would all be in keeping and would fit with a working diagnosis of a primary idiopathic overactive bladder.
Okay. Okay, sir. Sir, and treatment-wise, now the treatment will comprise treatment of constipation, and so what will be the role of anticholinergics and bladder neck relaxation, like solifenacin, or will it help, or should we go step by step and treat constipation first? And of course, biofeedback will be there, but other medical management.
Okay. So first thing to say is that generally it is quite common for children who have a primary idiopathic overactive bladder to be constipated. And the reason for that is that when you ask them to fill a chart, this has been done. And if you look at the fluid intake on that day, I'm pretty confident that that would not be a truly representative of what this girl does when left to her own devices, and she's attending school, etc. It's very likely that she consumes far less water because she's made the association between how much fluid you drink and how often she's going to need to go to the toilet. So the reason they get constipated is because their fluid intake is generally low. And the only point at which they might play catch up with thirst is once they come home in the evening, because they've got easy access to the toilet and they can go as many times as they need to. Because of the relative dehydration, because of the reduced fluid intake, the body then tends to get fluid from wherever it can. And in this case, it will reabsorb as much fluid as it can, making the stools hard and then causing a secondary constipation. So yes, you can give stool softeners or whatever you like, but it is primarily ensuring that they have a good fluid intake, which is evenly distributed throughout the day. So normally I say 250, 300 ml every couple of hours. So on a school day, big glass of water before they leave home, again at break time, then with lunch, then when they finish school, then again with dinner. And then that will bring them to a volume of, see, it depends again. When it's very hot here, you might even 1.5, 2 liters maybe may not be enough, depending on how much you're sweating, etc., etc. So fluid intake, number one. Yes, you can give temporarily some sort of bowel management in the form of either stool softeners or some form of medication like Movicol. Anticholinergics almost certainly would be the first line of treatment, and for me, it would be oxybutynin. I don't know if you get the what is called the slow release or the extended release form of the tablet, and that would be the preference because you just have to take it once a day, roughly around the same time in the morning, and then combine that with asking them to practice when they are at home during holidays, when they get the sensation or the urge to go, because they are scared there will be leakage, they will tend to rush to the toilet. So you can do all the other things, but if they keep rushing to the toilet, as soon as they get the urge to go, the bladder is not going to stretch. So you need to try and get that bladder to stretch, begin to stretch up. And the best way to monitor is to get them to repeat these frequency volume or bladder diaries roughly every 3 months. And what one would see if this was effective is a reduction in the number of times she needs the toilet, an increase in the voided volumes each time she does go. And only when the daytime capacity reaches a minimum on average of 250 to 300, you're going to see a resolution or a reduction in the degree of nocturnal enuresis.
Okay, sir. And sir, I had a last question. Now, in this case, like, should I have waited and repeated a Euroflow again instead of doing urodynamics? Like, was it like one of the indications to do urodynamics, or should I have waited and repeated a Euroflow, tried it again?
So, I mean, I would, on the basis of the symptoms and the rest of the findings, we would attempt a Euroflow, but sometimes when they have a really small bladder capacity, you're not going to improve things much. So I would have started empirically treatment with anticholinergics.
Okay.
The only point at which we would do invasive urodynamics is in somebody who is non-responsive to medical management. And we are then looking at escalating that. And in fact, that would include getting an MRI of the spine to ensure that there is no neurological abnormality. And then invasive urodynamics, because we are then thinking of potentially injecting botulinum toxin into the bladder. And for that, we need evidence that there is significant overactivity, which is there in this girl's urodynamic study. So all that is telling you is that, yes, your clinical picture is matched by the fact that she's got a reduced functional capacity, detrusor overactivity, probably marked urgency, which is reflected in the increased sphincteric activity where she's desperately holding on. And so still start medical management.
Okay. Thank you, sir.
Okay.
Thank you.
Thank you very much, Madhura. Thank you, Dr. Desai. We'll go on to the next case, which will be presented by Dr. Pushpa. Dr. Pushpa Yadav is a fellow in training with us. She's in the first year of doing a FNB in pediatric nephrology. We'll be presenting a case of PUV with the valve bladder.
Good afternoon, everyone. My case is PUV with valve bladder.
The screen is somehow. Can you see your own screen?
Yes, ma'am. Ma'am, is the screen not visible?
It's
At
very
least to me,
grossly
the screen
enlarged.
is visible.
Okay, then it's fine because. Yeah, go ahead, Pushpa. It's visible.
Yes, ma'am. My patient, 14.5-year-old boy, antenatally diagnosed to have bilateral hydrouretronephrosis. Postnatally, he was diagnosed to have posterior urethral valve with left grade 5 reflux. He underwent a left ureterostomy at day of life 10 and posterior urethral valve fulguration 4 times. Last was done when he was 2 years old. And then followed by that, ureterostomy closure was done when he was 2.5 years old. After all these procedures, his reflux resolved. He had history of recurrent UTIs and he was already receiving oxyspas. So when he came to us, before that, this is his first MCU in the neonatal period. And we can see that he has a dilated posterior urethra, irregular bladder wall, and a dilated tortuous left ureter. Then he came to us when he was 6 years old. And this is his MCU when he presented to us. He had increased urinary frequency with dribbling, recurrent UTIs. His MCU showed large bladder with irregular walls and no reflux. And he was already in stage 4 CKD with GFR of 22 ml per minute. So when he was 6.5 years old, considering that he was already having recurrent UTI and nocturnal polyuria, and his USG showed persistent significant post-void residue and a falling GFR, he was initiated on CIC and overnight bladder drainage. So clinically, his UTIs decreased. However, he continued to have growth faltering and reached CKD stage 5 by 8 years of age. However, his USG had shown decrease in bilateral ureteric dilatation and bladder wall thickness has also reduced after initiation of CIC and OND. He was initiated CAPD in October 2020 and as a pre-transplant workup, his MCU was done and UDS was done, and this was his latest UDS. This is a filling phase UDS. Sir, should I move ahead with the voiding phase?
Yeah.
Yes, sir. And this is his voiding phase UDS with a voiding volume of 171 ml. So this is permission to void from here. That's it, sir.
Dr. Desai, there are two questions. One is that what the bladder is already looking large and he's on CIC, but he dribbles in between, so we had no option, and it actually stopped with oxybutynin, so we had to give it to him. That was just for symptomatic relief. Would there be any other way of handling that? Hello?
I think Jyoti, Dr. Desai is not seen. He was as iPhone, right?
No, I don't think so. I
He
think
can't be
iPhone.
seen. He's maybe logged off or something.
Okay, was he iPhone?
Yes, ma'am.
Okay, then we'll wait for him to connect. Dr. Desai is just trying to reconnect, so we'll wait for a few minutes.
Sorry, lost internet.
No problem. Good to have you
Yeah.
back. Thank you.
No problem. No
We
problem.
need your
Okay.
expert advice on this.
No, so okay, so can you tell me what are the catheterized volumes that he normally gets when he does his CIC?
So usually he gets around 100 to 200 ml in every CIC. And in the
Only-
overnight drainage, he gets 500 to 600 ml right now.
Okay, and 100 to 200 ml is every how many hours?
Every 4 hours he does this CIC.
4 hourly, and
Yes,
he is dry between CIC.
If we try to stop his oxyspaz, then he has this wetting episodes in between the CIC. That was the reason we continued his oxyspaz. Even like we gave a trial in between after stopping, but then he has this wetting episodes.
Okay, and can you go back to the filling phase of this? And do you know if those little spikes at 40 ml and about 70 ml, whether those are cough or those are overactivity?
Those are overactivity. They are not cough.
Okay.
Because they would have been marked. They are done in our hospital just next to us. I know how these are done.
Okay. And move on from there. So that, okay, sorry, and go back again. So the point at which the, sorry, back again to the filling. So the point at which we are seeing the end of that filling phase is the point at which he's, I'm assuming, he's not voiding, is he? Or he's attempting to void?
Because we gave him permission to void later after this year. Like,
Yeah, but it has then gone into, yeah. So it is the sort of point at which he has reached capacity. And there seems to be a little bit of loss of compliance towards the end of filling. So I don't know what the volume is where that pressure starts to go up.
The volume is around 150 ml, like one.
Yeah. So beyond 150, it appears to be poorly compliant because the pressure has gone up. And in addition, he's got reduced voiding detrusor pressures, which would be in keeping with his incomplete bladder emptying and the need for CIC. So if you look at his functional bladder capacity for a boy who's nearly 15, it's a very small functional bladder capacity. And there appears to be some loss of compliance. So if you are going to consider transplanting this child, I don't think that this is a safe bladder to receive a transplant for multiple reasons. The capacity is not adequate. There appears to be a suggestion that there is a loss of compliance, and he's got reduced or significantly reduced voiding detrusor pressures. Maximum it is recorded at 33, but you can see that there is associated abdominal effort because the red line is also active. And so your voiding detrusor pressures are reduced. Did he empty well?
Yes, was.
On this, it suggests that he has emptied well.
He's emptied well. 171 ml is the avoided
Yeah.
volume.
Yeah. So the overall picture to me is going to be that this is a reduced functional capacity with impaired bladder compliance, reduced voiding detrusor pressures, although with reasonably good emptying, at least on this occasion. So yeah, it just depends on what renal replacement you're looking at, time frame wise, etc. Because he's still got a little bit of pubertal growing to go. So he's 14, 15. There's probably another 2 years and a bit of puberty. So I think any intervention would be determined by what the long-term renal replacement plan is.
Ms. Patel,
What's up?
answer the question.
Sir, no, I couldn't hear the question. We couldn't hear the last part.
What
What
is
renal
the current plan in terms of potentially looking at renal transplantation?
Well, so currently he's been worked up for this, and we are looking for a living donor for him. But yeah, we are currently we have put him on maintenance hemodialysis, and we want him in the near future to be enrolled or registered in this list of donor transplant.
Yeah, but this bladder is not going to be a safe container
Yes, sir.
based on what we are seeing here now.
But then
So okay, what would we have done if we had this situation? We would have a discussion about proceeding to an augmentation cystoplasty and continuing to catheterize per urethra. There's no need to do anything in terms of a mitrophin or anything. But in order to give this bladder capacity and address the impaired compliance, he would probably need an augmentation ileocystoplasty.
Okay. Okay, sir. Thank you, sir.
So you would not do a mitrophilis?
No, we wouldn't do it because if he's catheterizing, without any issues per urethra, there is no need to do a mitrophin.
Okay. And would you do one MCU before he goes for transplant?
He had an MCU, no, just before this?
No, sir. That was old one, that 5 years old one.
I think it was 2016 was the last MCU which was done.
Okay, I thought that MCU was along with this. So yes,
No,
you can do an MCU just to look for anything different in terms of what you're seeing on your urodynamic study. But
Okay.
that previous one, I think, looked more in keeping with what you're seeing with your urodynamics now.
Right. So what my question was, let's say this patient puts himself on the cadaver list. We are not going to know when he's likely to come up for transplant.
Correct.
So would you address his bladder
Yeah.
away just in preparation for whatever
Yeah.
is going to happen whenever it happens?
Yes, because at the moment, at least he's got a urine output. So it will allow
Right.
you to get that bladder
Ready
and ready,
right.
so that when it comes to transplantation, you can transplant the ureter directly into the bladder.
Right. Okay. Thank you very much.
No problem.
So we'll go on to the next case, which is actually a very short case, which will be presented by my colleague and the consultant, Dr. Jyoti Singhal. It's a patient who we need to know about bladder management. Over to you, Jyoti.
Ma'am, the slides are visible?
Yeah.
Yeah. So this is just a case to management issue without any urodynamics or bladder assessment. So we have a 2-year-old, 3-month-old boy with antenatal scan suggestive of bilateral hydrouretronephrosis. Though he was not evaluated postnatally for this, he presented with 2 febrile UTIs at 4 and 5 months of age, and then evaluated and found to confirmed to have bilateral hydrouretronephrosis with respective APD pelvis of 4.4 and 4.3 on right and left, with bladder wall thickness of 3.6 millimeter. So at this age of 5 months, he underwent the MCU, which showed a dilated posterior urethra, irregular bladder wall, and a right side grade 5 reflux. And this is the oblique view and a post-void view in the same MCU. Following this, he underwent right ureterostomy and endoscopic valve ablation at 6 months of age. And DMSA showed subnormally functioning right kidney with scars and with with left kidney function of 75% and no scars. After this, he was lost to follow-up when he presented recently. And currently, he has a good urine stream, no complaint of wetting of undergarments, and no episodes of UTI in last 1 year. His current creatinine is 0.46 with GFR of 75 ml per minute per 1.73 meters square. And his recent sonography shows a small right kidney with mild cortical thinning and scarring with moderate hydronephrosis. and left kidney with APD pelvis of 1.5 centimeter and left lower ureter of 7 millimeter and bladder wall thickness of 3.6 millimeter. So the pediatric surgeon has advised a repeat MCU, which was done last month. And this is his recent MCU with still showing the irregular bladder wall, though the urethra can't be seen, and we didn't have a post-void film for this patient.
So what has happened to the ureterostomy?
So the ureterostomy is still there. It's in situ. So the reflux is seen till the ureterostomy. He has a ureterostomy in situ still.
Okay. So it's an end ureterostomy, is it?
Yes.
Okay.
And so our question was key with this bladder image, and also there was a doubt that whether we can see a reflux on the left side also in the last film. Not sure.
Not sure. That doesn't look very...
Yeah, definite. So will initiating CIC and drainage help him at this stage, or do we wait? And when do we, till what time do we, when do we take that decision? Since he's 2 years old, it's difficult to get a Euroflow, and still for such young age, we are not that well equipped doing a urodynamics.
No, but again, the question is, clinically, he seems to be well. He's thriving. His renal function is reasonably stable.
Right.
He appears to be continent.
Yes.
No urinary tract infections.
After that, no. No, after the diversion.
So why would we think of changing anything? Have we got any ultrasound or anything to check on how well he empties his bladder when he voids?
The post-void was... Okay, I'll have to check. Can't remember here.
He has a ureterostomy, no? But he has a ureterostomy.
No, but the
And,
ureterostomy is an end ureterostomy. So I'm assuming that the other end, which you are seeing reflux into, is basically blind ending. And it's only the top end that has been brought out to the skin surface, which is draining that right kidney. That's why I asked, is it an end or is it a refluxing ureterostomy? Because they are slightly different.
no,
So what they mention is loop.
So that's okay. So then if it's a loop ureterostomy, which is a refluxing ureterostomy, i.e. both ends are connected in surface, then he is clearly refluxing out through that. And so adding CIC at this point is not going to be any value add, because he's leaking through that ureterostomy anyway.
And once the surgeon decide to close, then we'll evaluate again.
Yeah, so I mean, I'm not, again, it depends on, at the moment, his kidney function is good. He's continent, his renal function is stable. I think that at the moment, there certainly seems to be no rush to close that ureterostomy. There will come a point as he gets older that obviously, in order for him to be continent and no leakage of urine onto the abdominal wall, you would consider closing that depending on what the function is in that right system. So I think previously it was about 25%.
Yes.
Yeah, roughly 25%. But this is a small, abnormal, dysplastic system, dysplastic kidney, dysplastic system. So you need to evaluate function on that side and decide, whether it is worth closing that ureterostomy, because reflux at this point is still ongoing.
Yes.
So you're not going to be able to stop that. However, if the function in that kidney is less than 10%, then the question is, how much is that contributing to his overall renal function? And you make a decision on what you want to do based on all those factors. But at the moment, I think it's a very stable situation. You've got an outlet or a pop-off through the ureterostomy. So further intervention at this point, I'm not sure is justified. It would be worth trying to evaluate when he does pass urine, how well that bladder is emptying. So if the bladder is emptying nearly completely, then I don't see any benefit from further intervention like CIC or anything more.
Okay. Thank you, sir.
Thank you very much. So, are there any questions from the audience?
Yes, ma'am. Ma'am, I have two questions if you allow to that.
Yeah, sure.
Yes.
Go ahead. Dr. Desai, is it all right?
Yeah. Please, please.
Yes, sir. So I wanted to know how frequently you justify the diversion procedures in case of a PU valve. So like the case before this one in which they had done fulguration along with the ureterostomy. So if we have a facility for good fulguration available, then just because of reflux, do you consider doing the ureterostomy or not that frequently? We should touch that thing if we have a good fulguration facility available or not. So how frequently you admire doing the diversion procedures nowadays?
So it is very uncommon. Diversion is very, very uncommon. Our mainstay is going to be primary fulguration. The situation in which we would consider a diversion is if you've got a child roughly under the age of 3 with nearly end-stage renal disease, where you're looking at, as Jyoti will know, at Great Ormond Street, there is this huge push for preemptive renal transplantation.
Right.
So if they are pushing and looking towards preemptive renal transplantation, and it is the suitable candidate, i.e. you've got free reflux going up one or both ureters, then again, in order to make that bladder safe, because the bladder is in a process of transition, and therefore, if you're going to transplant, say, at age 2 or 2.5, there is no way we can ensure safety of that bladder other than by giving a diversion. So by giving a diversion, you then allow for the transplant to settle in, you allow for the renal function to settle down, and then as the child gets a little older, you revisit whether anything more is needed for the bladder. But other than that sort of fairly uncommon and rare situation, we do not prefer diversion.
Yes, sir. Okay. Okay, sir. Yeah.
It has to be on the basis of clinical. So, I think increasingly there is a tendency to act upon the results of investigations rather than on what is the clinical picture in front of us. So, if you have a child with valves with reflux, the first thing to understand is reflux before the valve ablation and the prevalence of persistent reflux after successful valve ablation, it drops by about 50%. Where reflux persists, it generally tends to be on the side of a poorly functioning kidney. So when you have a kidney that is very poorly functioning, in that situation, the reflux may not subside after valve ablation. But if that is not producing any symptoms, again, there is no indication to intervene for that.
Right. Okay. Okay, sir. And sir, I have like 2 or 3 cases who are briefly, they behave like having a obstructive system. Like in the infantile age group, one kid is around 1.5-year-old, another one is 2.5-year-old, whose MCU was sir, typically of obstructive in nature, showing some obstruction at bladder neck. And but the cystoscopy relieved no obstruction at all. There were no valves, and even the MRI showed like normal MRI. So there was no neurogenic component also. So here in where I practice, it's very difficult to evaluate in detail in terms of in such a young kid to get in the other evaluation. So this kind of patients, like with typical symptoms of bladder neck obstruction, like in adult, they do that primary bladder neck incision and all. But in pediatric at 1 year or 2 years, having such kind of, that bladder neck stenosis kind of a picture. So how do you think, like what would be the ideal way to manage such kids with normal system, no valves and normal, no neurogenic component, but purely very bad bladder to begin with. Like so.
So how have you defined, or how have you localized that there is a possibility of a bladder neck obstruction? So when you say obstructed picture, what do you mean in a 1-year-old? What do you mean?
So this kid had come from periphery. Unfortunately, I didn't have the image, but his MCU was typically showing a dilated posterior urethra with a very bad bladder, like a trabeculated, thickened bladder with bilateral reflux. And when we did the cystoscopy, we didn't find, the surgeon didn't find any valve.
So,
But it was, yeah. Right.
So again, first thing is that we are extrapolating the findings of an MCU to suggest that there is a possible obstruction. It is fine to exclude valves. Now, remember, the first thing is, in a normal child, particularly in the first year of life, or up to 2.5 until they toilet train, coordination between detrusor contraction and sphincter relaxation is immature. So it is quite common for you to get what would be a detrusor sphincter discoordination. So if you observe voiding in a normal baby, it's typically described as fractionated. So they'll get a stream, then it'll stop, then it may trickle, then it'll stop, then it may dribble, then it may stop, and then you may get another stream. Now, that is in a completely normal situation. Now, when you combine this with bilateral reflux, you have to understand again the pathophysiology of what is happening. So the bladder starts squeezing, but now you've got 3 outlets for the urine to go. 2 going upwards back towards the kidney, and the third that has to then go across the bladder neck. And you've still, because of age, got the detrusor sphincter discoordination. So when a low pressure outlet where to push urine back up into the kidney is going to occur at a much lower pressure than what would be required to open the bladder neck and get it across the sphincter, it will give you an impression that there is an obstruction there. But that is not an obstruction. That is just understanding the pathophysiology of what is going on by putting together all the different pieces of the jigsaw.
Okay, sir. Sorry, sir. Yes, sir.
Yeah. So if that answers your question, so here the primary problem is the VUR.
Right.
And again, same. So this is primary VUR, and therefore indications for intervention will be the same. You know, it doesn't change. You have ruled out valves, which is fine. So either you have to manage this conservatively with antibiotic prophylaxis. If it's a male child, we would offer a circumcision. And if and only if they're getting breakthrough urinary tract infections or something else is happening, then we would consider some form of intervention for the VUR. Okay,
because the bladder was also so much trabeculated, sir. So I couldn't associate. It was very,
The reason that is happening is because the bladder is never empty. So it is attempting to empty more often than not. So because it is shunting probably 50% up into the kidneys and 30-40% is going out. And so in half the time, roughly, that bladder is going to be full again. So depending on age, if they are voiding every 1.5 hours, that bladder is going to be full in 40 minutes or 45 minutes.
Okay. Yes, sir. Okay.
Thank you very much, Dr. Desai.
No problem.
Dr. Uma Ali ma'am, do you have any comments or anything else to say? Would you like to?
No, I think it was a very interesting session. You know, I enjoyed it. Lots to learn. And I think only thing is, I get very confused with this opinion on oxybutynin because I've heard so many different aspects of it. I think last few months ago, I attended a session where they said oxybutynin helps in remodeling the bladder wall. Is there any evidence for that it does it, and that is the reason that it is started early was the premises?
No. So, I mean, if you go into the pure science and the laboratory work that has been done, the ratio of collagen 1 and collagen 3, which in experimental models they've showed is altered, and which they hold responsible for some of the findings that you see in an obstructed bladder. Now, the only other experimental way in which they've shown that you can alter that is with ACE inhibitors. So, oxybutynin as an anticholinergic will not have any, there is no evidence that I am aware of where it has any direct positive impact on changing the structure of that bladder in terms of its different layers. Now, again, as I said, many ways to skin a cat. I think one needs to understand it's the chicken and the egg for me as to why are you getting overactivity. And if there is a good explanation as to why you're getting overactivity, and there is evidence that with doing nothing, I'm talking about now in the PUV population, that the overactivity settles with time in the vast majority, then I question why would I use anticholinergics in this situation. Now, the other situation in which oxybutynin is being promoted in lots of, so for example, in children with spina bifida and myelomeningocele, there are lots of people who believe in starting these children on anticholinergics and CIC from birth. And one of the statements that's coming out is that, oh, it reduces the need for augmentation cystoplasty. So far, to the best of my knowledge, there is no published evidence which has documented that. So I think that you need to have a clear understanding. So, I mean, if I wanted to question, I would question and say, okay, so why are you giving oxybutynin for up to age 5? What's the thinking behind that? And the answer is probably going to be that in the vast majority of children with PUV, by age 5, they no longer have overactivity. But that is happening naturally anyway. And usually before that, by the age of 3 or 4. So it has to be as to what are you trying to improve by giving anticholinergics. Now, some people argue that by giving the anticholinergics, you are protecting the upper tract and you are reducing potential exposure of high pressure. But overactivity, as we know, it is the sustained high pressure that is secondary to poor compliance that in the long term is detrimental to renal function. Overactivity on its own, whether idiopathic, whether neurogenic, on its own short, sharp bursts of overactivity do not threaten the renal function. So, I mean, so long as people have a clear reasoning for why they use something, it's fine. It's fine. I think we are quite happy because our experience for more than now, I've been managing these for about 25 years, and we almost never use anticholinergics, and our outcomes are I would say pretty good, very good, comparable to any other center, and therefore we are quite happy with our approach to how these patients are managed. That is not to say that, I mean, of course, people use it, and I'm very open to evidence which will show that actually the outcomes are better. But as yet, I haven't seen that.
Is there any role for use of alpha blockers to relax the bladder neck?
Yeah, again, very selective. So, I mean, this.
Sorry, antagonist.
No. So, primary blood neck obstruction is a very, very, very uncommon condition. I initially trained as an adult urologist before I retrained as a pediatric urologist. And we have a 3-volume textbook of urology written by Campbell and co. And there's literally about 4 lines in that textbook on primary blood neck obstruction. So it's a very rare condition, number one. Number two, if you want to read, the person who's done quite a lot of work on primary bladder neck obstruction is, in fact, a pediatric urologist from New York, Kenneth Glassberg. So if you search Kenneth Glassberg and primary bladder neck dysfunction, you will be able to see, what are the clinical symptoms. What are in 20 years, I have had 2 patients, and both of them were young adult, as in teenage boys. And then he will, in his paper, when you go through, in terms of the diagnosis, he talks about something called, so you have to do EMG, and there is something called a lag time, which is the time from which you have a desire to start voiding, and the gap after which the void actually starts, which is where it's one of the diagnostic factors in diagnosing primary bladder neck obstruction. Trying to diagnose it in children, newborns, and very young children is fraught with a lot of risk of misdiagnosis. Alpha blockers.
Is there a role for it in PU valves after valve ablation?
Not really. I mean, again, the pathophysiology of why you get so the primary bladder neck dysfunction or obstruction seems to be more of an autonomic phenomenon, whereas the secondary bladder neck obstruction, when it occurs, which is infrequently, correctly diagnosed, is due to essentially muscular hypertrophy and an inability of that muscle to adequately relax. So the alpha blockers, again, having advantage of being initially trained as an adult urologist, alpha blockers and all these medications, what they are doing is that they are relaxing some element of not just the bladder neck, but even the capsule that goes around, what will subsequently be the prostate gland. So it is not going to directly cause a selective smooth muscle relaxation at the level of the bladder neck only. So we have trialed it in children with valves, but with very poor success.
But is it true that
and my last question? Sorry. Yeah, go ahead. Yeah, my last question is not connected to drugs. Is there an age in the bladder that looks like it requires an augment? A particular age up to which we need to wait before we consider augmentation?
So technically, the answer is no. From a practical sense, the need to do an augment is by and large with an understanding that this bladder, whatever the underlying condition is hostile and is therefore going to damage either the native upper tract or an impending transplant. So generally in very young children, because it's surgically quite a significant undertaking, something that's going to be then a lifelong part and parcel of this person's life, the long-term risks of, stone formation, and most worryingly in the long-term risk of malignancy, would make the decision to do an augment something that we have to be absolutely certain that there isn't an alternative. We try very hard to try and ensure that the family, and where possible, the children are also at a point where they can understand the impact of what they're going to have done and are compliant with what is required after having an augmentation. So technically, you can do it at 1 year of age, 2 years of age, not a problem. But it is very rarely necessary that early on, because you have alternatives like diversions, which can tide you over that period.
Thanks, Divyesh.
No problem. No problem.
Just going back to the alpha receptors, is it true that, that the number of receptors actually increase when there's a bladder pathology? So therefore, they're likely to respond to alpha blockers.
I don't, okay, the distribution is not selectively. So, yes, there is an increased prevalence of alpha receptors around that bladder neck and prostatic capsule region, but there are alpha receptors in the rest of the bladder as well. I am not aware that in the presence of bladder pathology, their number increased. I'm not aware of that.
Okay.
And I don't know if there are experimental studies that have specifically looked at that.
Right. Okay.
But
So,
alpha blockers, as a general rule of thumb, I am not aware of their efficacy being good in the pediatric population, whatever the underlying condition is for which you are using them.
okay. Right. So I think we'll end today's session. Thank you very much, Dr. Desai, for
Not at all.
you really make the sessions, answers very simple. And after each session, I feel wow, it's really very comprehensive, and you make it simplified. The emphasis is on making patients' symptoms relate to whatever we are investigating.
No, absolutely.
Sorry, I interrupted you.
I was fortunate enough to have had the training under certainly, for probably most of pediatric urologists around my age, would have trained with Mr. Philip Ransley, who was not only an excellent surgeon, but he actively encouraged you to question, to challenge, and to try and form an understanding as to what is going on here. Not just accept because X does this, therefore that is the truth, or that's the way it needs to be done. What is the evidence? Does it make sense from a physiological perspective, pathophysiological perspective? Join up all the dots. And, once you start doing it as a routine, you will find that there will be things that you'll say, okay, this is not fitting in with 90% of the picture. So I'm not sure that we need to give, I'm not saying you ignore it, but I'm not sure you need to give it as much weightage, because there are 90% of other things are more reassuring. So I think having that holistic approach, I've always found very helpful.
Thank you very much. I think it's a good message for all of us. I'd also like to thank Manoj, Madhura, Pushpa, and Dr. Jyoti Singhal for contributing to today's session, and for all the rest of the people who attended it. So, thank you.
Okay, all the best, and happy Anant Chaturdashi to everybody.
Thank you. Thank you for finding time for us.
No problem. Bye-bye.
Bye.